Welcome to the deep dive. We're hitting the ground running today with a really critical topic for your MSRA prep, hyperosmolar hyperglycaemic state, or HHS.
hmm
We've gone through a whole load of notes, sort of pulled out the essential info you need to get a handle on this condition.
Yeah, the goal is to make it clear, memorable.
Exactly. Make it stick. We'll even throw in a few memory aids as we go.
Sounds good. So HHS,
Yeah.
let's clarify what really sets it apart. It's a serious medical emergency.
Right.
We're talking really, really high blood glucose, usually over 33.3 millimoles per liter or 600 milligrams per deciliter if you use those units, plus severe dehydration.
And it's mainly in type 2 diabetes.
Primarily, yes. And the big differentiator from DKA diabetic ketoacidosis is that you get minimal ketones, like
Right.
hardly any, and no significant acidosis.
Okay.
So the pH stays above 7.3, bicarbonates generally over 15. It's serious stuff, often seen in older people, and sadly has a higher mortality rate than DKA.
Why that? The higher mortality.
Well, it's probably a mix of things. The patients are often older, maybe have more underlying health issues. Plus, HHS can creep up more slowly, so diagnosis might be delayed compared to the more dramatic onset of DKA sometimes.
Okay, so let's just cement that definition. HHS means severe high sugar, leading to really concentrated blood that's the high serum osmolarity, typically 320 or more.
Yep.
But crucially, like you said, hardly any ketones, no real acidosis like in DKA, and it comes on gradually.
Yeah, often over days, even weeks sometimes. The dehydration just gets progressively worse. That slow burn can make it tricky to spot early on.
Right.
Here's a little tip to maybe help remember it. Think of the H in HHS, high sugar, high osmolality, but also H for hardly any significant ketones or acidosis.
Oh, I like that. H for hardly any.
Yeah.
That's quite neat. Okay, so we know what it is. Now let's dig into the causes of the etiology. What's going on underneath?
Well, fundamentally, you've usually got underlying insulin resistance plus a relative insulin deficiency.
Well, relative deficiency.
Meaning the body isn't using its insulin well, rather than not having any, like in type 1 diabetes. There's usually still some insulin around. And often the liver is also producing too much glucose.
Okay, so the body's not responding well to insulin.
Exactly. Cells struggle to take up glucose. But these underlying issues usually need a push, a trigger, what we call precipitating factors, to actually tip someone into full-blown HHS.
And these triggers can be varied.
Oh, very. Infections are a big one. Pneumonia, UTIs, things like that.
Yeah.
They cause a stress response. Hormones get released that push sugar up and make insulin resistance worse.
Makes sense.
Then there are other medical conditions, medications, sometimes just poor diabetes management.
Okay, let's talk medications first. What drugs should we be aware of? The notes listed quite a few.
Yeah, there are several. Metformin can be an issue, especially if someone gets dehydrated from being unwell. Diuretics obviously can contribute to dehydration. Beta blockers, some H2 blockers, calcium channel blockers too. Even things like chlorpromazine, certain anticonvulsants like phenytoin, glucocorticoids, steroids, basically.
That's quite a list. Steroids are a common culprit for high sugars generally, aren't they?
They certainly are. And then, thinking about the diabetes itself,
Yes.
well, sometimes HHS is actually how type 2 diabetes first presents. Someone didn't even know they had it.
Wow.
Or it's someone with known diabetes whose control has just slipped badly. Maybe they stopped taking meds, intentionally or accidentally, or perhaps issues around self-neglect, or even, sadly, neglect by others.
And it's not just meds and diabetes management. Other illnesses play a role, too.
Definitely. Think major physiological stress, a heart attack, a stroke, pancreatitis, a pulmonary embolism, acute kidney injury, an acute abdomen,
Okay.
hyperthyroidism, burns, Cushing's syndrome, even a GI bleed. All potential triggers. And don't forget things like severe heat exposure, hyperthermia or hypothermia, substance misuse like alcohol, cocaine, MDMA.
It really is a wide range of possibilities. Okay, quick question for you listening. Imagine a 75-year-old, type 2 diabetes, comes in with HHS. What broad categories of triggers pop into your head immediately? Think infections, meds, other illnesses, their diabetes care.
Good exercise.
Yeah.
So that covers the why. Now, who's most at risk? Let's look at the risk factors.
Demographics seem key. Older age, definitely. Type 2 diabetes, as we've said. Obesity and a sedentary lifestyle also increase risk. And ethnicity seems to play a part.
Yes, studies show higher rates in certain groups, like African Americans and Hispanics, and having other health problems, comorbidities, adds to the risk. Things like high blood pressure, cardiovascular disease.
And anything affecting fluid balance seems really
That's
important.
hugely important. If someone can't drink enough, maybe due to cognitive impairment like dementia, that's a major risk.
Right.
Or if they lose excess fluids, perhaps poor kidney function, and of course not sticking to their diabetes medication plan is a big one.
The notes also mention some specific groups.
Yeah, people in nursing homes or those living alone without much support. Patients with dementia, as we mentioned, people taking sedatives. During heat waves, definitely. Anyone immunosuppressed.
Okay.
Even, interestingly, children on long-term steroids who get gastroenteritis can be at risk.
So a way to picture this. Think of an elderly person, type 2 diabetes, maybe a bit confused. It's a heat wave, they forget their meds. That's like a perfect storm for HHS.
That paints a very clear picture, unfortunately. Okay, so let's get into the nuts and bolts of how this happens in the body, the pathophysiology.
It kicks off with that super high blood sugar causing osmotic diuresis. What does that mean exactly?
Right, so there's so much glucose in the blood, the kidneys just can't reabsorb it all like they normally would.
Okay.
So glucose spills into the urine. And glucose is osmotically active. It pulls water with it, so you lose massive amounts of water and electrolytes like sodium and potassium too, just through urination.
And that massive fluid loss jacks up the serum osmolality, makes the blood thick.
Precisely. The blood volume drops, the remaining blood gets super concentrated, hence the high osmolarity over that 320 mark. But here's a tricky thing.
Yeah.
They might not look as dehydrated initially as you'd expect for that amount of fluid loss. The fluid inside the blood vessels is relatively preserved at first compared to, say, fluid loss from severe diarrhea.
That's a crucial point. They could be much sicker internally than they appear externally.
Mm-hmm.
And the insulin problems are still chugging along.
Absolutely. The insulin resistance and relative deficiency mean glucose can't get into the cells properly for energy, so it just keeps building up in the blood, making the hyperglycemia even worse.
Right.
And all this dehydration and electrolyte chaos causes water to shift out of body cells, trying to dilute the concentrated blood. This cellular dehydration, especially in the brain, is what causes a lot of the neurological symptoms, the confusion, the coma.
Okay, so a quick way to grasp the pathophysiology. Sugar pulls water out, blood gets concentrated, brain gets unhappy.
Huh? Yeah, that sums it up pretty well. Concise. So when you've got someone with high sugar and altered mental state, HHS is high on the list, but what else do we need to think about? The differentials.
Well, number one is ruling out DKA, isn't it? And the key, as we keep saying, is the lack of significant ketones and acidosis in HHS.
Exactly. Check the pH, check the bicarb, check the ketones. pH above 7.3, bicarb over 15 points towards HHS.
What else?
Well, you might think about acute pancreatitis, though, that usually comes with severe abdominal pain. Sepsis can cause altered mental state and dehydration. A stroke, a CVA, could potentially mimic some neurological signs. And sometimes you hear the term hyperglycaemic hyperosmolar non-ketotic coma, or HHNC. That's basically the same thing as HHS.
So look at the whole picture, but those ketone and acid-based results are vital for telling it apart from DKA.
Couldn't agree more. Okay, let's zoom out a bit. What about epidemiology in the UK? How common is HHS?
Our notes say it's less common than DKA overall. Definitely seen more in older folks with type 2. But interestingly, there's this trend now of seeing it more in younger adults, even teenagers. Sometimes it's the first sign they even have type 2 diabetes.
Yeah, that's a worrying reflection of the rise in type 2 diabetes generally, isn't it? The actual incidence in the UK is thought to be pretty low, maybe less than 1% of all diabetes-related hospital admissions.
And any particular groups more affected here?
Well, echoing the risk factors, higher rates are seen in African American and Hispanic communities in the UK. Likely a complex mix of genetic factors, socioeconomic influences on diabetes prevalence and management.
Right.
And obviously, the overall rates depend on how common diabetes is and how well it's generally managed in the population.
Makes total sense.
Yeah.
Okay, let's get practical. What does a patient with HHS actually look like? The clinical features, signs, and symptoms.
Okay, you're looking for someone who is profoundly dehydrated and has that very high glucose. Key symptoms: extreme thirst, peeing a lot, at least initially, before they get too dehydrated, dry mouth, feeling really weak, generally unwell.
And the altered mental state is key.
Absolutely critical. It can range from just mild confusion or drowsiness right through to coma. Some people get visual disturbances too.
You mentioned neurological deficits can be more obvious than in DKA sometimes.
Yeah, things like weakness down one side or other focal signs, sensory changes, motor problems can crop up more often in HHS. And then the obvious dehydration signs on examination. Dry skin, dry mouth and tongue, poor skin turgor.
That's when you pinch the skin and it stays tinted up.
Exactly. And they might have low blood pressure. In really bad cases, you might see signs the circulation is failing or even organ failure starting.
So on first impression, they'll look pretty sick, wiped out, definitely dehydrated, maybe confused. What about vital signs?
Often tachycardic, fast heart rate trying to compensate for the low blood volume. Hypotension, low blood pressure is common. Breathing might be rapid, but usually not that deep, gasping, Kussmaul breathing you see in DKA. Temperature can be up if there's infection, or sometimes low in severe cases. Oxygen sats might be down if they have lung issues.
And a proper head-to-toe exam will find more.
Definitely. Check skin turgor. Look for rashes. Any source of infection. Head and neck. Sunken eyes, dry mouth. Maybe check the throat and ears for infection. Feel the lymph nodes.
Right.
Chest and heart. Listen for pneumonia, signs of heart failure. Check for murmurs suggesting endocarditis, signs of an MI. Abdomen. Check for tenderness, signs of an ileus. And a really thorough neuro exam is vital.
Assessing what specifically?
Level of consciousness, orientation, thinking skills, any neck stiffness, suggesting meningitis, Kernig's, syncranial nerves, power in the limbs, coordination, reflexes, sensation. Really comprehensive.
It sounds like you need to be thorough. Memory tip, maybe. Picture someone looking incredibly dry and confused, but they don't have that fruity acetone breath or the deep, fast breathing of DKA.
That's a useful contrast. Okay, so we suspect HHS based on how they look in their history. What tests do we order?
Bloods are obviously first up. Glucose level going to be sky high, over 30 usually. Electrolytes. Sodium, potassium, bicarbonate. Bicarb, usually normal or just a bit low, helps differentiate from DKA.
Yep.
Kidney function urea and creatinine, essential to check for AKI. Acute kidney injury, which is really common. Urea will also be high just from the dehydration itself.
And ketones.
Crucial. Blood and urine ketones should be normal or only slightly up in HHS. That's a key difference from DKA. Other basics too, full blood count, liver function, CRP maybe, looking for infection or other issues, imaging, chest x-ray maybe, CT if needed based on symptoms.
And we need to confirm the high osmolality, right?
Absolutely. Serum osmolality will be way up over 320. Lab can measure it directly or you can estimate it.
How do you estimate it?
The formula is roughly 2 times sodium plus potassium, then add urea, then add glucose. All in U1L. Gives you a good ballpark figure.
Okay. Any other tests needed?
Yeah, you'll need to repeat the kidney function and electrolytes pretty often to see how they're responding to treatment. Blood and urine cultures are vital to hunt for infection. And arterial blood gas, ABG, confirms no significant acidosis pH over 7.3, normal and in gap usually. Maybe check CK levels or cardiac enzymes if you're worried about muscle breakdown, rhabdo, or a heart attack. ECG, chest x-ray for heart-lung status. And then other tests, depending on what you suspect the underlying trigger is. Maybe a lumbar puncture if meningitis seems possible.
All right, a full workup. So we've diagnosed HHS. How do we manage it? It sounds complex. It needs careful handling, definitely inpatient care, close monitoring. Priority number 1 is fluids, intravenous fluid resuscitation.
What fluid?
Usually start with 0.9% saline, normal saline. How much and how fast depends on how dehydrated they are. And if they have heart or kidney problems, you need to be cautious about fluid overload. But generally, you're aiming for maybe 3 to 6 liters in the first 12 hours, then replace the rest of the deficit over the next 12 or so. Keep a very close eye for fluid overload signs, crackles in the lungs, rising JVP.
Okay, fluids first. What about the electrolytes that are all over the place?
Got to correct those carefully based on frequent monitoring. Sodium needs careful watching as fluids go in. Potassium is tricky. It might be high initially if they have kidney injury, or it might drop rapidly once you start insulin. So replacement needs careful titration based on levels.
And insulin. When does that come in?
Cautiously, and usually after you've started fluids, especially if ketones are low or absent. You don't want to drop the glucose too fast before the circulation is restored. We typically use a low-dose, fixed-rate IV insulin infusion, something like 0.05 units per kilo per hour. Gradual reduction is the aim.
And we absolutely have to find and treat the trigger.
Cannot stress that enough. Find the infection, treat the MI, whatever it was. That's key to getting them better and stopping it happening again. Then there's supportive care, monitor heart rhythm, neurostatus. Some might need ventilation if they're very unwell. Daily foot checks are important in anyone with diabetes.
Then monitor response closely.
Very closely. Frequent checks of osmolality, sodium, glucose. You want to bring the osmolality down slowly and steadily. Drop it too fast, and you risk cerebral edema or osmotic demyelination syndrome, serious brain complications.
Okay. Anything else?
Prophylactic anticoagulation blood thinners like low molecular weight heparin is usually needed because they're dehydrated, immobile, and at high risk of clots like DVT or PE. Keep strict fluid balance charts. Encourage drinking fluids once they're alert and safe to swallow. And always get senior help involved early or if things aren't going to plan.
That's a lot to coordinate. You mentioned a mnemonic for the first steps.
Yeah, a simple one. Fluids first, then insulin, find the cause. Helps keep the priority straight initially.
Fluids first, insulin, find the cause.
Got it. So what's the outlook for someone who gets HHS, the prognosis?
It really depends on how severe it was, what other health problems they have, and how quickly they got effective treatment. With good, timely care, many do well.
But as we said earlier, mortality is higher than DKA. Often quoted around 10 to 20%, maybe even higher in some studies. That's largely down to the patients often being older and having more comorbidities. It's significantly higher than DKA mortality.
Really highlights how serious it is. How can we try and prevent it?
Prevention is key. Good diabetes education is vital, especially sick day rules. Patients need to know what to do with their medication, monitoring, and when to seek help if they get ill.
Right.
Healthcare professionals need to be aware, recognize at-risk patients, spot triggers early, and anyone who's had HHS before needs extra support and education to try and avoid it recurring.
Makes sense. Finally, what are the potential complications we might see with HHS?
Well, the direct consequences of the severe dehydration and electrolyte chaos are common things like hyponatremia, hyperkalemia, acute kidney injury or failure. Cardiovascular problems like arrhythmias or even heart attacks can happen. Neurological damage is a big worry, cerebral edema, focal deficits.
And less common ones.
You can get ischemia or infarction, lack of blood supply to organs like the heart or brain, blood clots, DVT, PE, lung problems like ARDS, clotting disorders like DIC, multi-organ failure, muscle breakdown rhabdomyolysis, that rare brain issue, central pontine myelinolysis, and of course complications from the treatment itself if not managed carefully, iatrogenic problems.
Wow, it really feels like that initial state of high sugar and dehydration can just cascade through the body, stressing almost every system.
That's a good way to put it. It's a systemic crisis.
Okay, well that wraps up our deep dive into hyperosmolar hyperglycaemic state. Let's just quickly recap the absolute must-knows.
Okay.
Remember HHS, high sugar, high osmolality, but minimal ketones or acidosis. Severe dehydration is classic. More common in older people with type 2 diabetes. Management priority is fluids first, then careful insulin, and always find and treat that underlying trigger.
Spot on. And maybe a final thought to leave you with, given that we're seeing type 2 diabetes rising in younger people, how might that change the typical face of an HHS patient in the future? Something to ponder.
Definitely food for thought. For more great resources to smash your MSRA, do check out passthemSRA.com and freemsra.com. Thanks for tuning in to this deep dive.